next speaker we have is Dr. Lucinda Halstead. She's an associate professor in the Department of Otolaryngology, Head and Neck Surgery, and the Department of Pediatrics at MUSC. She received her medical degree from George Washington University and completed her residency in otolaryngology, head and neck surgery in the combined Tufts University, Boston University residency program. Currently, she serves as the Vice Chairman for Resident Education in the Department of Otolaryngology, Head and Neck Surgery. Her interests in laryngology, swallowing, voice, performing arts, medicine, and pediatric otolaryngology led her to found the MUSC Voice Center in 1987. In 2000, the Voice Center expanded and she became the medical director of the MUSC Evelyn Trammell Institute for Voice and Swallowing. Every year, Dr. Halstead acts as a laryngologist for the internationally renowned Spoleto Festival, USA. She lectures nationally and internationally on the topics of laryngopharyngeal reflux disorders and pediatric voice and swallowing disorders. Among other societies, she's a member of the American Society of Pediatric Otolaryngology and the Collegium Medicorum Theatri. Thank you so much for joining us, Dr. Halstead.
Thank you very much for letting me be here today. And it's always lovely to hear Sharon talk about her journey. So today, what I'd like to share with you is, as a laryngologist, someone who specializes in voice and swallowing, what I think about when patients come to us with these multiple cranial neuropathies, especially the Chiari malformation. So some of this is going to be a little bit conceptual. It's certainly, to me, treating patients like Sharon or patients with Chiari malformation, it's not cookbook, and I'm going to share some of the thoughts that I have when I'm seeing patients with these disorders. I have nothing to disclose. So this is a patient who has Chiari, who has bilateral vocal fold paralysis. She has a little bit of motion, so we could say that she has partial paralysis. And you can see that she's a little short of breath. Her breathing, both inspiratory and breathing in and out, is noisy. And it happens all the time. And eventually, she was getting very fatigued, and certainly her family was getting very distressed at the noise. So when we look at someone like this, it emphasizes in many ways what I think is the challenge of Chiari, because unfortunately, you have the worst of almost all worlds. So I'm hoping that we can look at the dynamic interaction between airway, voice, and swallowing. And then I'd like to, as Sharon's alluded to, talk to you about our team and what our team, which is not just me, it's our voice therapists and also our singing voice therapists that can bring to the table to treat patients with multiple cranial neuropathies. So I'd like to think about the whole airway neurologic system. So when I look at someone who's having trouble breathing, I start thinking about their airway. I start thinking about how their ability to breathe is affecting their swallowing and what impact it's having on their voice. So if you kind of think about things, of these three things, what is it in this slide that is essential for survival? Is it your airway? Is it your voice? Is it swallowing? What is essential to keep your body and your heart going. So basically, swallowing is essential for survival. If you can't eat and have nutrition for your body, then you can't survive. Your airway, being able to breathe, is essential for survival. Without that, your brain can't function, your body can't function. So what about your voice? Obviously, I spend a lot of time with that because I work with singers. But the voice reveals that which is unique to each of us. Therefore, emotionally, it is vitally important. But it's actually not essential for survival. You can survive without talking. Not to say that we want to, but when I'm looking at where are we going to make trade-offs, how am I going to balance all three of these things to give you the best outcome? So when I look at a patient, that's what I'm looking at. How is their airway? How is that airway and the disruption of that airway affecting the timing of their swallowing? And how is all of that also impacting on their ability to communicate? So this is my team. I have, as the laryngologist, obviously I do the diagnosis and look at the larynx and prescribe things and work with my team of the speech-language pathologist who can give exercises for the voice, exercises for swallowing, and in many ways sometimes kind of creeps into the physical therapy domain with some circumlaryngeal massage and upper neck massage. So what about the singing voice specialist? Believe it or not, there are certain functions and behaviors of the larynx that only by super training and aspiring to make certain sounds, to elevate the palate in that way, and also engage your limbic system, that make a huge difference. We have a variety of patients with a variety of neurological problems for whom singing is their route back. So in the Chiari, as Sharon has actually really beautifully demonstrated, we have the mechanism is really the downward traction of the brainstem and the sort of up and over of the cranial nerves. So there's this tension as they're where they're exiting out of the foramen magnum. So it's kind of a kind of a teeter-totter type thing. So as Sharon lifts her arms up, her brainstem goes down, and then so the arms go up, the brainstem goes down, and these guys go meh, so they're getting pulled back. And that's why that pressure will cause her to lose her voice. And you can see that there's a lot of, it's not just, I mean, it's all those nerves. The glossopharyngeal nerve, the vagus nerve, your laryngeal nerves, your pharyngeal nerves, they're all there. So Sharon has already done this for me, thank you. So here we are in this area. So this is an X-ray of a sagittal cover of the head where you have your larynx, you have your esophagus coming down here, and then your swallowing mechanism here with your tongue, pharyngeal wall, palate. And you can see, I'm introducing this now, here's your epiglottis, here's coming down to your esophagus, tongue will be here, palate will be up here, because we're going to be showing you some things. In terms of the larynx, this is what a larynx looks like. And so these are your vocal cords or vocal folds. These are the joints that open and close your vocal cords called the arytenoids. There's your windpipe. This is your epiglottis, which folds over everything here, and you swallow back here. And we saw a little bit with that patient with stridor, with the Chiari, how the vocal folds can sometimes not open and close. But here's a little example of how vocal folds work. And when I'm looking at vocal folds, I'm looking at them with something called stroboscopic light, so I can see how the vocal folds wiggle. And if they're wiggling as mirror images of each other, I know that all of the nerves are working correctly. Okay? And if they're not, or we don't see, if we see an asymmetry of opening, then we know that there's nerves that are not working correctly. So back to our patient with the vocal fold hypomobility or immobility. She's short of breath. She can't get breath in. She's feeling tight, choking sensations. She has the noisy breathing. And the more it progresses, the more it kind of feeds into itself and it gets progressively worse. So as we're looking at treating someone like that, I look at how big is that opening? Is it really tiny, as hers was, or is it as wide as a normal larynx, or is it somewhere in between? So when I look at someone, I find out how, I look at the size of their airway and I say, and ask them, how are you when you ambulate? Is your airway good enough to walk across the street or get to the mailbox? For your normal daily activities, is it adequate? And then we look at the vocal folds and see how they're moving. Is one moving? Are both of them moving? And more importantly, can you close them and keep them closed? Or can you open them and keep them open? Depending on the degree that you can do all of those things will lead us down the aisle to, I'm going to do this procedure or this procedure, and or this therapy, recommend a different kind of therapy. So it's voice and swallowing, breathing and swallowing are just completely intertwined. What affects your breathing affects your swallowing. So we look as you're swallowing to see how much your difficulty breathing is affecting the timing of your swallow, if the anatomy gets distorted, if the timing comes off so that you aspirate. So based on that, then we talk as a team about what do we think the prognosis is? Are things progressive? Are things reversible? Do we need to talk about long-term palliation or attenuation of disease process? And basically what the family and family's priority and the patient's priorities are. So this little guy has Chiari. And actually has a shunt, and he came in short of breath because his shunt was malfunctioning. So you can see he doesn't have very much of an airway. And once his shunt was fixed, you can see that now he can open his vocal folds. Not perfectly, but much better, and he had a much better airway. So what did that do to this little guy's swallowing? Come on. So here what you can see on the swallow study is, here's his epiglottis. So you can see that nothing's really going down because the brain is going, it's time to swallow, but now the larynx is in the wrong position. It's time to swallow, now the larynx is in the wrong position. And then finally what happens is that it gets all confused and he aspirates. And you can see see that right there, and I think it's coming right over here now. There, okay? Because the brain can't get these two conflicting signals to gel into a coordinated swallow function. So when we look at that, obviously we're looking at aspiration risk. So the inability to sustain glottal closure, which is really difficult for Chiari's. even though their vocal cords are kind of close together, they never close and they never open. So it's the worst of both worlds. They have aspiration risk, they have a poor breathy voice, they can have vocal bowing or one vocal fold that's not moving like Sharon, or ones that just move a little bit or maybe just have a mild degree of impairment. And again, for the Chiari, they usually have bilateral vocal fold hypomobility or immobility. So we look at those and look at the degree and say, okay, what can we do in terms of therapy? And these are just examples of different neurological diseases that I treat. And you can see that some of them are more therapy, some of them are more surgery, some of them are kind of 50-50. So again, treating the Chiari is very difficult because it's bilateral, the airway is usually narrow at rest. You have aspiration risk, poor voice, and poor exercise tolerance. Why do you have poor exercise tolerance? Because you can't close your glottis to be able to climb up the stairs. You can't generate intrathoracic and intra-abdominal pressure to lift your feet up or to carry a basket of laundry up the stairs because you have to close your glottis to do that. And if your glottis is open, you can't pick it up. So you have a glottis that's too open. However, you have a glottis that's not going to let you play tennis either. So it's hard for you to be active. It's hard for you to be able to do all the activities of daily living that you want. And then what about your voice? Your voice is breathy. It lacks inflection. And it's very frustrating because, as we said, you know, our voice is that which is unique in all of us. It is our soul. And when that goes, you lose a huge part of who you are. And it's really emotionally devastating. So what can we do to treat glottal incompetence? One of the first things that we do, if it's physiologically feasible and safe, is to do voice therapy. The nice thing about voice therapy, these are all muscles. Just like for the physical, these are all muscles, and many of these muscles can be retrained, either with speaking therapy, with swallowing therapy, and in some cases, singing therapy. So we can train the accessory muscles of the larynx, we can train the respiratory muscles, and in the same time, for other neurological diseases, we can also help them in train cognitive functions so that they are better prepared, especially our Parkinson's patients. The nice thing about voice therapy, I say there's no adverse side effects. Most of the time, I think that's true. Every once in a while, you can never say never. But it's great. It's truly a great thing, and I'm a huge proponent of the multidisciplinary medicine therapy paradigm. So, okay, we've done some therapy, but we need to tune things up with a little surgery. So what kinds of things can we do? If the glottis is open and we just can't get it to close so that when you're swallowing, you're aspirating, sometimes if there's enough opening so that one vocal fold is moving enough, then we can push that other one over so this guy doesn't have to work so hard, okay? And we have several procedures that will do that. They're all called laryngoplasties. One, you can do an injection of gel into the vocal folds to push them closer together. And for some, depending on the width of the gap, sometimes we go in through the neck and put in implants in through the thyroid cartilage to push the vocal folds together. Sometimes if there's a problem with the arytenoid, we might turn that arytenoid closer into the midline as well. So here's an example of someone who has just bilateral superior laryngeal nerve paresis. And you can see in this particular instance that the vocal folds are bowed. Okay, so they look like these little, they look very floppy here. I lost it. There it goes.
Good.
And so you can see that
scale.
he hardly closes at all. Okay.
Okay, and really high. Okay, again.
And this was devastating because this guy is a professional singer. So we pushed the vocal folds together with some implants. Now we could do that because look at how widely he opens his larynx. Okay, so he was safe.
Okay, lower.
We could look at that and say, okay, he's safe enough to do that.
A little louder.
So a little bit more of what we would see in a Chiari that doesn't have complete bilateral paralysis, but does have a variety of laryngeal nerves out. This person has a recurrent laryngeal nerve out, so the left vocal fold's not working, but they're also floppy because both of the superior laryngeal nerves are not working.
Breathe.
So you can hear how breathy,
Breathe.
but that airway is okay. Okay.
And one more time. E. Low. E.
And you can see how that vocal fold is bowed because the superior laryngeal nerve's not working as well as the recurrent laryngeal nerve. So when I look at something like that and they're aspirating and they can't talk, they're exhausted, which is what we see with a lot of our Chiari people, we say, okay, they met the first, they successfully passed the first hurdle. The glottis is okay. They have enough of an airway that if I push things over, they won't obstruct and not be able to breathe. So for this particular patient, we did move the vocal fold over.
Beautiful.
And it made things a lot better. Okay, well, stop. So, the results of doing a laryngoplasty is that you have increased loudness of the voice, better vocal quality, and because you can close the glottis, you can generate intrathoracic, intra-abdominal pressure, and pressure to swallow. It improves your swallowing. So those are things that are fantastic. All right, what's the downside of all of this? When we do this, depending on how widely the airway can open, we can cause varying degrees of airway obstruction. And I warn a lot of patients, you know, when we push things over, a lot of you are going to snore, and that might drive your spouse out of the bedroom. And it's real. They can have mild shortness of breath and some mild inspiratory stridor, a little bit of that. But occasionally it could be severe and we'll have to take the implant out. So then what do we do to, if the vocal folds, your airway is inadequate, but the closure is too small, like our first patient with the stridor. Okay, so now she's going, she's having swallowing problems because she can't close and she can't open. She's short of breath. So what can we do to open up her airway? In some patients, and we're looking more and more about this with people who are having neurologic problems, that you can sometimes use Botox to help that. The problem with Botox is that it's episodic. It usually lasts about 3 to 4 months. And so you have this peak and valley, and when you're talking about breathing, peaks and valleys are not necessarily a good thing. Sometimes we take parts of the vocal fold or part of the arytenoid to open up the back of the larynx, but try to preserve voice. But usually, again, there we're having a conversation of the more I open up that airway, the softer your voice is going to become. And so you have to think of those things. These are things that are very important. Do I make the voice soft and breathy if you're a math professor at a college? Probably not. So what kinds of things can we do that can also help both of those things when people want an excellent voice and an excellent airway? And this, I'm going to tell you right now, is not necessarily the primary choice of patients. But we can do a tracheotomy and place a button, which is very low profile and translucent, so that they can, and has a tiny speaking valve, so they can have their voice, but they also have a wide open airway. But they have a prosthesis in their neck, which is a huge disadvantage for some people, and it's a huge stigma. But for many people, it has worked very well. So I sit there and I lay it all out, and I say, these are the things we can do. These are the things that are going to affect your voice. These are the things that are going to affect your swallowing. And you tell me what's important to you. You help me make these choices so I can give you back the life that you want. I mean, I can do a lot of things, but I need to consider where you're coming from, what's important to you. And there are some people who say, I don't care about my voice. I don't care if I sound like this. I just don't want anything in my neck. And then I have other people like the math professor who says, I have to have my voice. I don't care if I have something in my neck. And everybody, it's a continuum from here to here. So let's look a little bit more at the swallowing. Again, we're right back to that whole area here of the epiglottis, the vocal folds, your esophagus, base of tongue, palate, and the interaction of these things. When you look at it, I'm always amazed that we manage to not have to have our lungs vacuumed out every other week for stuff going down the wrong way. So we do things that are called modified barium swallows, and at the Evelyn Tremblay Institute, they have perfected a system for looking at this, which is called the MBS-IMP. So this is their rating scale. They look at what happens at the lips, what happens in the tongue, what happens at the base of the tongue and the pharynx, what happens at the epiglottis and pulling the larynx forward with the hyoid bone, and how things go down. And everything is rated. And you have a scale, and we can make an impairment scale for each person. So here's a person who has an almost normal swallow. If they were normal, they wouldn't be in our office. Okay, so this particular person has actually a little bit of escape of the barium before she's really ready to swallow. There it goes, boom. But the rest of her swallow is fantastic. She had inversion of her epiglottis. She had good excursion of the larynx so that the upper esophageal sphincter opened, and she was able to swallow normally. So we're going to look at, there's the hyoid bone. This is going to kind of puddle down, but we can look really at this area here. And she's lightning fast because she's normal. Everything just goes zoop. Now, some people with neurological impairments, like in Chiari, you can see now that this part was fine, but there's no stripping wave of the pharynx. The epiglottis doesn't move over, the hyoid bone doesn't come forward, and things just kind of, they kind of just pool around here, and they're choking and they feel like there's something in their throat, they're coughing and they're clearing. So again, one of the things that we can do, a lot of it is therapy. We can modify the diet. We can modify maneuvers to divert the flow of the bolus to one side or the other. If there's, like with Sharon, there's a weakness on one side, that weakness will cause things to pool in that area, and then they'll fall over into her airway. And then if we can't get the esophagus open. If there's any strictures or fibrosis, sometimes we can dilate an opening. If it's too small, we can Botox it, and sometimes we can cut the muscle to make the UES a little bit easier to open. Again, I'm a huge proponent of therapy, and there's tons of great exercises that our voice therapists give people. And I'm not going to go through each of them, but I am going to do a little bit on this one, because this one should be near and dear to all of our hearts, because all of us probably are swallowing pills. It's called the Misako maneuver, where you place your tongue between your teeth and swallow hard. Okay, so you're swallowing against resistance, and it's strengthening the base of the tongue. And if it doesn't hurt, you're not doing it right. Okay, so why is that important? Is because when you can get that base of tongue strong and pull that base of tongue forward, you can get those pills down. My favorite story, my anecdote for this, is one of our patients, a more senior woman, was having voice therapy, and she mentioned to our therapist that she was having trouble swallowing her pills. So she was taught this particular maneuver, and after doing it for 2 weeks, she could swallow everything. And she was so excited that she taught it to her bridge group. So I have this fantasy of all of these ladies, because nobody belongs to just one bridge group, of all of these little bridge groups across South Carolina where they're sitting around doing the Misako maneuver. So in summary, Chiaris present with the most challenges because they have the worst of each world. And conservative management, I think, is best until we know the recovery is plateaued, and then we can say, here's where we are, how can we move forward? I want to thank my team for their inspiration, and thank you for coming. So we have tons of questions?
Yeah, I have a question.
Yeah.
With the baby, you said that they needed to fix the shunt, and that helped.
Yes.
What do we see with shunts? Do they need to just adjust the shunt, or is it the placement of the tube?
Sometimes they just get, either the tubing becomes disengaged, or sometimes there's a problem with the setting. And for that little child, he just needed a shunt revision, and when they did that, his airway improved.
Thank you.
Any other questions?
So about just general hypermobility, EDS, maybe not Chiari at all, but maybe some cranial, cervical, some instability, but not, anything, maybe it's bad, maybe it's not bad. Do you see any problems with that? Just being hypermobile and not being able to close down effectively, with the swallow, for instance?
Yeah, again, what you're looking at there is if this instability, when they're moving it, that is causing a partial paralysis of the nerves, or causing things to just go into spasm.
Okay.
And so again, trying to build up the accessory muscles to support that, I think, is really important. I'm not sure that answers your question.
Yeah, no, it's just, and I'll have to talk to you later about
sure.
that, because you have the Chiari side,
Yeah.
then you have just the hypermobility
Right,
side, where
right.
a lot of my patients are teenagers. They're not quite there yet, but they still have issues. So, at what point do I send them to somebody like you?
Oh, I would think that we would start them right away.
Okay.
Yeah.
Okay.
Yeah.
I would say immediately, because I had hypermobility issues and it worked. Because I was with the swallowing, I had the same, it held at one point, and I was hypermobile, and I had worked on some of that swallow. I didn't even know that that's what that thing was, that you had been doing some of that swallowing. But because you can strangle real easily with people that have the hypermobility, just like she's talking about. Any of the tongue exercises are beneficial with anybody that has stuff.
See, and I get patients that come in with no diagnosis at all except for hypermobility from a primary care physician. They've never heard of EDS, they've never heard of Chiari. So here they are in my office saying, help me, I'm hypermobile. And then taking, their history and their symptoms, and the parents are involved. I'm hearing this stuff, and it's a lot of stuff coming from everywhere. So sometimes I'm like, where do I focus, as far as helping them find help for certain things. So if I am hearing symptoms, I should send them sooner than later then.
I think so.
Okay.
And I think one of the things I always tell our patients is, if they come in with an array of symptoms and I'm looking at them and they go, well, and I say, well, I may not have a diagnosis for you, but I know how we can start looking. And I may not be the one to find the answer, but we can start on that path and start looking. I know where to ask some questions.
Right.
Yeah.
See, and that's what these patients need help.
They need
answers. They need somebody just to listen to them and to start somewhere with them, because they're overwhelmed, in so many ways. So that's good. Thank you.
Absolutely. Yes.
Thank you for an excellent presentation. I would be curious, when you have patients who come with Chiari's, or most of the time you know that they are Chiari patients, or have you found in the course of your experience in practice, when you've had people come in, maybe they don't realize they have Chiari or they're hypermobile, and because I know in some places there's truly people are still learning about this for the first time. Have you been able to lead to a Chiari diagnosis, or say?
Yes. Yes.
What would you say is the percent of the time in the past, maybe 5 to 10 years, you've seen that over time? People coming in already knowing their Chiari versus seeing their experience and saying, you might be onto something. They need to pursue another course. Would you say
I would, yeah, that's a great question. Actually, somebody else had already asked it before the conference. I do occasionally get people who do not know that they have Chiari, or people whose diagnosis of Chiari has been missed before, just because they're older and all of their treatments being based on x-rays that the technology isn't as spectacular as we have today. And but I do get people who are sent to me for shortness of breath, and I look down there and they have bilateral vocal fold paralysis, and I'm going, can you raise your arms? And they're going, no. Yeah, so I don't get a lot, but I do get some. I think that's one of the things that is, if I may say so, great about laryngology, is that there's almost nothing that doesn't affect your voice and swallowing. So you really have to keep a very broad differential when people walk through the door. And they always surprise you. It's really challenging and wonderful.
Thank you.
Mm-hmm. Well, again, thank you for inviting me.
Thank you.
Thank you so much,
You're
Dr.
welcome.
Halstead. That was a wonderful lecture. Thank you. Appreciate it. And so glad you were able to do this for us. This is something that so many of our patients experience, and they get frustrated because they don't have the people who understand and are able to treat them. So I think this is really going to help providers too when they're looking to try to figure out what to do. So thank you.
Well, you're welcome. It's my joy. Thank you.
All right, so I guess that's it for tonight. Our next meeting is planned for August, and probably be a lecture on dysautonomia things, POTS, things involving the autonomic system causing people to pass out and drop. So dysautonomia doesn't mean anything to some people. So yeah, a lot of our patients experience POTS where they just start to faint. So we're hoping to have a lecture on that at the next meeting. So I hope everyone can come. Thank you for coming tonight.
Thank you.
I have another question.
Sure.
Speaking of dysautonomia, what about the relationship between dysautonomia and swallowing dysautonomia and those issues as well?
There can be.
Okay, because I've had a couple patients come in and say, well, I have this issue with my swallowing and with my speech because of my dysautonomia. And, you know, me being a PT, there's so much to look at, and sometimes it's a little overwhelming, so I put it aside, but that was one of the things I was thinking about earlier. Just,
Yeah.
you know,
There can, it's like not 100%, but,
Okay.
you know, a lot of the people that Dr. Patel and I are working with who have chronic cough or vocal fold paralysis that just is not diagnosed by the usual workup. We've now been looking at compression of cranial nerve 10 at the brainstem, and a lot of those people have dysautonomia. So, yeah.
This was a great talk, really.
Oh, thank you.
It's a subject that we don't hear. No, I know,
but I
right?
can't even think of them all because there's so much.
Yeah.
And I think a lot of times with swallowing, I've found with the patients that we deal with, we talk to them about a speech therapist. There's nothing wrong with my speech. They don't understand that it's swallowing too.
Yeah.
Yeah.
So you get like stricture too? I mean, esophageal stricture and things?
I will treat the upper esophageal sphincter if it has like a web or something like that, or if it's in spasm. But you get much below that, and that goes to the GI guys.
people.
Yeah.
So hiatal hernia, it's a GI guy.
It's a GI guy. Yay!
You know, because a lot of my patients have that too. And
Yeah. So, there's a lot of things if you want to kind of trot down the reflux path, and people with hiatal hernia can have not only just reflux, they have problems sometimes with the hiatal hernia of their lower esophageal sphincter opening so that they reflux. But they can also have some problems with esophageal dysmotility, so the esophagus isn't contracting really well. And so by working that up, there are, for people with small hernias, there are different kinds of therapies we can do, medical therapies that help tighten the lower esophageal sphincter or improve esophageal contractility before you have to kind of think of a surgical correction. So.
yeah, because I was along those lines. I don't know how bad the hernia would be to cause my patients complain of choking, or not so much choking, but not being able to breathe for the moment until they get past the spasm or whatever that is.
Right.
And then, and it's scary a little bit for them.
Yeah. Well, again, the reflex that's there, you have like a gastrolaryngeal reflex. So that if it's either the hiatal hernia that's causing escape or things just leak out, especially like I have a whole bunch of high-level athletes, and they're pounding, and so things are squirting up through their upper esophageal sphincter. When your lower esophageal sphincter chemoreceptors get stimulated, it sends a message to your brain that aspiration is imminent. Okay, and so that's the warning. It's going, aha. So what does the larynx do? It gets ready so that instead of being like this when the liquid comes up, it's like this. It just has to go like this versus like that. Okay, so and that's why, and a lot of times it doesn't come all the way up. So but they still get that shortness of breath. It's a basic protective reflex. And so that's why, a lot of our athletes, when they're exercising, when that happens, then they can't play soccer, they can't finish running, they can't, they get short of breath, they start to pass out, they get dizzy. It's depending on if they stop their activity, then it goes away. But if they're, if they want to finish that race for that scholarship, it can be really bad. And so So yeah, there's so many reflexes like that that cause, to, again, your airway is essential for survival, so your brain and your body is doing everything it can to keep your lungs functioning, your heart beating, and your brain oxygenated. And so that reflex, it's lightning fast.
It is.
This is really one of the best talks I've had in a long time.
Oh, thank you. Oh, my goodness.
I don't think we have one on the.
There is not anything like this on the website. Nothing at all. And Strider and all is a big
Oh,
deal.
great. Yeah,
that's
that's
really-
great.
When I see it's posted, I'll email you and let you know.
Thank you.
But it won't be from my MUSC email.
Okay.
Because I'm retired.
I know, you told me, traitor.
So you're not getting rid of me, but I'm retired.
So the American Physical Therapy Association released an article yesterday on me starting a physical therapy clinic as a subspecialty for Ehlers-Danlos syndrome and everything related. So I think the word's going to get more and more, pushed out to my profession to kind of come back for all of this education and the need for this education. And I was at our, so I joined a franchise so that I could take away some of the business, stress. And so I was in Vegas last weekend with my national franchise, and we are a new franchise, and we have a strong education platform that we're trying to create, and they're very interested in me at some point coming in and developing this national this training program to train other physical therapists just about all of these issues. So the word is starting to get out. Things are starting to spread, which is so exciting. But there are so many parts of the physical therapy has to understand that we have to be able to reach out to the team to be most effective.
Yeah.
So it's just a cool thing.
Yeah,
And
this is so great.
yeah, and so your side, I just really want to understand more, And me, I have EDS myself, and I think I've, as a physical therapist, spent my life trying to figure things out. I'm a stroke survivor as well. I was aphasic and dysphagic and dysphagia and all of that stuff. So part of me says, how much of this was my stroke? And 19 years out this month, how much of this is just me aging with my collagen weakening, even over time, because I have a lot of speech issues. I don't tonight, but a lot of times I have a hard time clearing my throat and things like that. So being a PT and having this, it teaches me a lot, hearing lectures like this from these other professionals of these other things that are going on, which is, it's just so exciting. So thank you.
Oh, you're welcome.
So exciting.
And it's just fascinating to see what you're doing as well. I mean, I think this is fantastic.
Finding
What
our
everybody's,
ways.
together. Yeah, together.
I think it's so exciting that we're going to have more physical therapists throughout the United States trained and understanding and aware of all this. So many times providers don't even want to recognize that patients have these issues because they don't know what to do with them.
Because they don't know what to do with them.
Yeah.
Exactly. They get overwhelmed by all of this, and people come to me, and other providers say to me, so you see EDS patients. So is there a big psychosocial overlay, social, just overlay that you see in these patients? And I said, well, we're creating it as clinicians for not trying to learn about these issues, because these issues are real. And so that's what I tell them. And I said, you need to educate yourself. You need to, if you get a patient, don't turn them away. Learn, find somebody who does understand.
Don't tell them that they're crazy.
Right, don't tell
this
them
is
they're
just,
crazy.
because they're not. They're just not. They're not.
And my patients have taught me more than anything. It's our patients are so educated.
Yeah.
They know they're going to educate themselves.
Right, right.
It's really neat. So we're going to get there.
Yeah, great.
So thank you.
Oh, you're welcome.